Hello, good morning, everyone, and welcome to one more lecture, which is about nasal polyps. Like today, our topic is nasal allergies with nasal polyps. Let me tell you first of all that uh, the allergies. Uh, I'm not going to talk about the allergies in this lecture because we had covered that thing in the previous lecture. That is, allergic rhinitis and all those. Okay, so of course, like nasal polyps, they are formed in people who have long-standing history of allergies, and that's the reason. Like this one can develop in anyone. If you remember, like my previous lecture, which was about allergic rhinitis or hay fever or chronic rhinitis. So we had discussed all those things. So of course, like uh, nasal polyps get developed in the people who have the history of all these chronic allergies. Before starting nasal polyps, like they are simply what you can say non-neoplastic masses of the mucosa. Okay, the polyps are non-neoplastic masses of mucosa. Okay, they can develop in any place, like polyps can develop in intestines. Okay, intestinal polyps are there, as well as nasal polyps are there. So whenever, like wherever there is mucosa, it is getting what you can say hypertrophic, enlarged, and there is edema of that. It can give rise to polyps. uh, because we have already covered that topic, which is called as all the allergies, and one of the thing which you will study, which you have already done in internal medicine, is called as asthma. For example, people who have asthma, um, like they have a long standing uh, history of allergies as well, and they can also get nasal polyps. But how we approach the patient of nasal polyp, because nasal polyp people, the most common complaint they come to the doctor is called as nasal obstruction. Okay, so we must know how we have to approach anyone who is having nasal obstruction. So, what are the causes of nasal obstruction? Okay, and it's a very common thing, by the way. All of us, we had nasal obstruction. Okay, if not like in the normal days, but whenever we get any infections, upper respiratory tract infections, we get nasal obstruction. So there is nasal cavity, as we know. Okay, there is nasal septum. We all know this thing, and what you can say, there is nasopharynx. Okay, and like what are these? These are basically three important parts or structures, you can say. Uh, the first one is cavity. The second one is the septum, which is in the mid, and the third one is the cavity, which is behind, which opposite to which connects with the oropharynx. Okay, and which goes down below to the uh, larynx and simply to the airways. So, and also, there is some systemic causes as well. Systemic causes also are there. They're not so important, but of course, we have to talk about that. So, when we talk about nasal obstruction, so see what are the causes which can, well, like what the things which can occur in nasal cavity, and they can lead to uh, the development of the nasal obstruction. So, some of them they are acquired, and some of them they are congenital. So, congenital. Okay. Now, in acquired, we had already covered that topic, rhinitis. Okay, so rhinitis is one of the cause, acquired cause. Okay, I'm writing rhinitis, guys, because remember there is a lot of type of rhinitis. There is type of rhinitis, like in refer to my previous lecture, in which there is atrophic mucosa. Of course, like when the mucosa is going atrophic, um, then of course they don't have nasal obstruction, rather they like there. Okay, yes, they may have, because if there is too much crust formation. So I talk about that in my previous lecture. Okay, so rhinitis can be allergic, can be chronic, can be acute, can be vasomotor. So simply, rhinitis can be one of the acquired causes of nasal obstruction. Um, and to be more specific, you can simply say rhino sinusitis. Okay, because most of the time, they occur in a group together. Then one of a very important causes foreign bodies, especially in kids. Okay, foreign bodies can cause obstruction due to allergies. There can be enlarged turbinates, tumors can be there. Tumors can lead to um, obstruction, and the tumors again, they can be benign and they can be malignant. Simply, benign, of course, when the tumor is benign. So remember, one of the tumor which is benign is which we are going to study today, that is called as nasal polyp. Okay, so this is one of the benign tumor. In malignant tumors, I talk about benign tumor. By the way, one more benign tumor which can cause obstruction, but not in nasal cavity, rather behind that. I talk about that, like angiofibroma. So of course, polyps are benign; they are not cancerous, but malignant tumors can be there. Simply, all these reasons can be there in the nasal cavity, which can lead to nasal obstruction. Congenitally, in nasal cavity, a very important thing you have to remember, like choanal atresia. Like when the babies are born, basically they don't have a patent, you can say, nose. Okay, so what happened? Like when they breathe by mouth. Okay, so when their mouth is closed by feeding, they turn blue. Why? Because they cannot breathe the nose. So why? Because they have atresia. So we can simply divide that part. Okay, uh, and open their nasal cavity. A choanal atresia, there can be any type of cyst, like dermoid cyst can be there, um, glioma, a congenital type of tumor, but not so important. Coming on the nasal septum again, nasal septum, we can again classify nasal septum causes into two things, like you can say the benign, like the congenital causes as well as the acquired causes. But in nasal septum, either it's congenital, either it's acquired. They both are same one. For example, a very 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 common thing, and many people, like even the general population, they know about that thing, that is called as DNS, or deflected nasal septum. Okay, so septal deviation, like which general population they call it as, like I got DNS, the bone inside my nose is not straight, rather, it is deviated, and that's why I have, what you can say, more and more and more nasal obstruction. And sometimes, of course, we go for surgery called as SMR or septoplasty. Septal hematoma, due to any trauma, due to any other thing, or you can say, or it could be abscess. Okay, abscess, abscess can be there. Any hematoma or abscess due to any cause, as well as dislocated septum. Okay, in the case of trauma, many people there. So now you can see that these causes can be congenital, can be acquired. Um, After that, nasopharynx. Now, in the nasopharynx, when I was talking about the anatomy, you remember, like there is the presence of, when we will talk about the anatomy inside, in the throat, there is a structure called as adenoids. Okay, adenoids. So, what are adenoids? These are basically lymphoid tissue, and same like tonsils, they are located behind in the nasopharynx. When they are enlarged, it can obstruct the backside of the nasal cavity, or simply the nasopharynx. Okay, so hypertrophy. Okay, and that's why when they do tonsillectomy, many of the times they shave the adenoids as well. They remove them. Okay, so tumors can be there. Okay, and simply polyps can be there again, which is our discussion today. Okay, angiofibroma can be there, which is a very important type of tumor. Not so common, but it happens mostly in males, children, boys, and it looks like polyp. And it is angiofibroma made up of vessels, guys. Like whenever you are suspecting angiofibroma, never touch that, because if it start bleeding, it's hard to stop bleeding from this one. And angiofibroma is a very important differential diagnosis when you are talking about polyps. Okay, and carcinomas or malignancies, simply malignancies in nasopharynx. Okay, they can lead to what you can say obstruction. Systemic causes, guys, not so important, but of course they are there. They are granulomatous diseases like sarcoidosis and like Wegener's granulomatosis. There's granuloma formations all over the body, so granulomas can form in the uh, nose as well, and of course it can lead to obstruction. Diabetes can lead to obstruction, and not so important. Like if you will study diabetes, you are not going to find diabetes like the clinical presentation of diabetes like they write nasal obstruction, never. Okay, and many of the rheumatological conditions in which there is vasculitis. Okay, though not so important cause. So I'm telling you, systemic generally are not so important cause, but of course like they can do cause, and you can found it in the book, so that's why it is important. So anyhow, see, actually, why I'm talking about this thing, because we are studying something clinical, and or we are discussing polyps from clinical point of view, and the patients, when they come to you, they complain about the symptom, and the symptom in case of polyps is either the patient have obstruction in the nasal cavity, or either they feel some mass, they can see some mass, and that's why they will come to you that okay, uh, we see like there is something in our nose, and this can be the only presentations of this nasal polyps. Okay, and then of course we examine them, we take history, we examine them, and we try to sort out why there is what kind of masses there. Either it's nasal polyps, either it's deviation, either it's a abscess, either it's a hematoma, either it's a angiofibroma, uh, xyz, whatever, right? So now if you can see over here, nasal polyps are simply defined as non-neoplastic. They are not cancerous. So they are non-neoplastic masses of edematous nasal or sinus mucosa. Okay, and uh, we classify them into two main types. One is bilateral ethmoidal, one is antrochoanal. So now, uh, why what you can say, uh, we divide this into two main categories, because one is bilateral and one is unilateral. This topic is very short, guys, and nasal polyps are important, but they are not complicated. Like you would understand what I'm saying. So we will discuss these two types of polyps one by one. So first of all, bilateral ethmoidal. Okay. Now, as the name shows, that bilateral means, of course, like most of the time, this polyps, they are bilateral. Okay, and um, simply, uh, what is the causes? You can see over here, like they arise from the lateral wall of the nose. Okay, here they are showing you the lateral wall of the nose, and usually from the middle meatus. Okay, usually they arise from the middle meatus. Okay, So simply, they are multiple, they are bilateral, they arise from the lateral wall of the nose, usually from the middle meatus, and common sites is like they arise from unicate process or bulla moedalis or ostia or medial surface or edge of the middle turbinate. And now, I refer to my very first lecture in which I was talking about the anatomy. You can see that one and you can found like how the structures are related. Okay, so this is the point, and allergic nasal polyps almost never arise from the septum or the floor of the nose. Okay, and this is a very important clinical point. Like most of the polyps which are due to allergies, they almost never arise from this one. Etiology of this one is a little complicated, guys. Like before going to etiology, I would rather like to talk about the pathogenesis. Basically, nasal mucosa, particularly in the region of middle meatus and turbinates, it become edematous, as you can see here. Okay, and why it became edematous due to the collection of extracellular fluid. Okay, so now when the mucosa become edematous, like in the start, these polyps are sessile. Okay, and sessile is like I'll show you that one. If I can, I have some picture over here. See this one have a stalk, okay, a stalk. So sessile one, they don't have a the stem or like the connection part. Rather, they are just swelling of a mucosa like this, right? Like this. See, you cannot see any stem or stalk, with this one. So that's why they are called as sessile. So simply, um, in the start they are sessile because when the mucosa, it started swelling. So it is not a hanging structure, rather it's just a swelling of that part. But later on, due to like chronically, due to the gravity, what happens, they started hanging from like, or the mucosa. It is now that ball or that mass is connected with the other mucosa by a connection. We call it a stalk, okay, or simply it is pedunculated due to gravity and excessive sneezing, okay. So in the early stages, guys, surface of the nasal polyp is covered by ciliated uh, columnar epithelium. Of course, like that is the normal mucosa, but later it undergoes metaplasia, okay. Like I think like all of you know like what is metaplasia, what is dysplasia, right? So simply it goes under metaplasia, and it changed to transitional and squamous type on exposure to atmospheric irritation. And simply the submucosa show large intracellular spaces filled with the fluid, and we can also see eosinophils and round cells in that. So that is what you can say the pathophysiology of this one. So now how they are formed is simply, uh, see, we can categorize the thing into three main categories. One is inflammatory conditions, which I already told you, like allergic rhinitis or asthma, and then there are a few things basically in which the cilia are not motile. Like I will discuss about, there are different conditions in which the cilia are not motile, and the third main cause is when there is abnormal composition of the secretions. For example, in cystic fibrosis, all the secretions in our body, they are basically thick. Okay, they are viscous. They have like they are more concentrated. Okay, so now uh, the different causes of uh, what you can say, polyps is very complex. Like the etiology is very complex, and exactly it's not well understood, like how they arise. Um, they may arise in inflammatory conditions like rhinosinusitis, and as I told you, in motility disorders or abnormal secretions. Okay, so one of the cause of etiology, like why we are studying it, is the continuation of, you can say, the previous lecture as well. Chronic rhinosinusitis. Okay, so polyps are seen in this condition, chronic rhinosinusitis. Okay, uh, no matter it's allergic or non-allergic, simply in both of the conditions we can see this one. And one thing is called as NAIRS. What is NAIRS? It's basically non-allergic, this one is non-allergic rhinitis with eosinophilia syndrome. Okay, it is non-allergic rhinitis with eosinophilia syndrome. So of course, like this one is a type of, you can say, chronic rhinitis in which polyps are most commonly formed. Asthma, as I told you, many people who have asthma, they can develop aspirin intolerance. Okay, uh, one third of the patients who have aspirin intolerance, guys, they can show polyps. One third of the patients who have aspirin intolerance. And there is something called as Samter's triad. These are the people who have asthma, they are intolerant to aspirin, and they show polyps. This is called as Samter's triad. And now cystic fibrosis, this is an example in which there is abnormal mucus secretions, allergic fungal sinusitis, then there is cartilaginous syndrome. Like simply these are the people who like who have situs inversus, like the organs which are located on the right side, basically they are located on the left side, like livers on the left side. Okay, we call it as situs inversus. So many people, they have like cartilaginous syndrome. Then there is Young syndrome. These are the people who have pulmonary conditions, as well as sinus conditions, as well as azoospermia. They cannot produce sperms. Okay, and Schwarz syndrome, you will study this condition in rheumatology. These are the people who have granuloma formations in different parts of the body, as well as vasculitis, like their vessels, small vessels, become inflamed. They have eosinophilia, they have fever, they have asthma. So collectively, we call it as Schwarz syndrome. Nasal mastocytosis, again, it's a form of chronic rhinitis in which nasal mucosa is infiltrated with mast cells. That's why it is called as mastocytosis, because the mast cells are too much in number. So it is called as mastocytosis. We simply uh, like when the people, they have this thing, they have too much mast cells. We check their blood, which can check their skin for allergies. Okay, and what we found, like they don't have much eosinophils. Rather, what you can say, like this one, NAIRS have many eosinophils. They have too much mast cells. So anyhow, this is all the etiology. So going on to the symptoms, guys. Symptoms are very easy. See, they are multiple in number. They are bilateral. They can occur at any age. Okay, but mostly seen in adults. So the most common presenting symptom is the nasal obstruction. Okay, this is the most, because both of it is present bilaterally most of the time. So the patients, they come and complain of nasal blockage, nasal stuffiness. Okay, and due to the blockage of both, or bilateral blockages there, they complain of anosmia, like they cannot smell the things. And again, you have to connect this topic with the previous topic, guys. Anyone in which there is nasal blockage bilaterally, they will have more sinusitis, they will be having more headache, they will be having more problem with sense of smell, they have more sneezing, more nasal discharge, and all these things. Okay, sometimes if the mass is too much big, see, you can see the mass protruding from the nose. Okay, so this one is like, you can see, they exactly look like this. See, bilateral, both of the sides are there. How they look like? See, they look like grape structure. They are shiny. They are glistening. Okay, so see now, uh, when we do examine them, of course, like we do anterior rhinoscopy. Like, it's a small thing you can see, just to open the nose and see the things inside easily. If the person nostrils are so big, sometime maybe you don't need a rhinoscope. You just need a good torch. So see, as I show you, these polyps, they look smooth, they look glistening, shiny, grape-like masses, and their color is pale. Their color is not red. Okay, and I told you, they can be sessile, they can be pedunculated, and if they look pale, when you touch them, they don't bleed. This is very, very, very important thing to remember. When you touch them, they don't bleed. Okay, they are bilateral, they are multiple, and sometimes if it is long standing, they are bilateral. So what happens, uh, because they are continuously exerting pressure on the lateral wall, so many of these people, they have broadening of the nose. Okay, and if the polyp is so big, of course you can found it protruding outside from the nostril. Okay, and if the person have some sort of infection, maybe you will found a purulent discharge with associated sinusitis. Okay, so very easy features simply. And how we diagnose them, guys? We take history, we do examination, we do clinical examination. Not so important, but you can do CT scan to check for paranasal sinuses, to exclude if there any bone is involved, to exclude like either there is any sign which can suggest like a cancer or a malignancies. Okay, so you can do a CT scan for that simply. Uh, Otherwise, this one is not needed. Okay, but yes, CT scan do help in planning for the surgery. Treatment. Once you have diagnosed that someone have bilateral ethmoidal polyps, what like treatment? First of all, I always tell you guys, remember the treatment under three headings. In this one, what are the conservative managements you can do in these patients? For example, in these patients, what are the conservative management, or conservatively what I can do? See, basically, anyone who have this thing, this polyps, like before going to the surgery, we can, like, if you found some allergies, for example, someone who have allergy, and they know like they are allergic to something, we ask them to avoid that. If they have some pets in the home, we ask them to remove that. Simply, uh, we ask them to control their symptoms if they can. Otherwise, uh, we have to go for the surgical management. You can give them antihistamines. You can give them a short course of steroids. Okay, uh, simply uh, to see like how the things are going. Okay, and if, for example, these things are working, of course there is no need of any surgical treatment. But if the patient is not controlled by conservative management or antihistamines or short course of steroids, then of course surgery. In surgery, one of the things which you can see here, polypectomy. What is polypectomy, guys? One or two polyps which are pedunculated, they can be easily removed by with the help of snare. You can see over here. They can take a snare and they can just remove that. Okay. But if, of course, they are multiple or sessile, we need some special forceps. Um, there is one of the surgical approach called as intranasal ethmoidectomy, and when the polyps are multiple and sessile, basically we have to they require the uncapping of the ethmoidal air cells, by intranasal route. So this is called as intranasal ethmoidectomy. Then there is extranasal ethmoidectomy. This is like simply indicated if someone had done intranasal ethmoidectomy and it is not proven well effective. Okay, so it's a repeat surgery, you can say. Uh, and what they do, like they approach the ethmoid cells by what you can say, the medial wall of the orbit, the eyeball, medial wall of the eyeball, they can approach the ethmoid from there. Okay. So this is how they approach the ethmoid cells by the medial wall of your orbit. Okay, the medial wall of the eye socket, simply you can say. Then there is transantral ethmoidectomy. Transantral means what? That, okay, again, first of all, intranasal ethmoidectomy is quite easy to perform and less invasive, you can say, as compared to extranasal ethmoidectomy. But whenever it fails, then they go for extranasal or transantral. So transantral is only indicated when infection or you see the changes in maxillary antrum, for example. So what they do is something called as Caldwell look approach. This one, Caldwell look approach. So this is the Caldwell look approach. Okay, they approach the maxillary area, maxillary sinus by this one. They create a hole above your what you can say. They create a hole above your you can say the gingiva, just to approach the uh, what you can say maxillary area, and from there they can reach to the ethmoid cells. And the last one is, of course, nowadays there is endoscopic surgeries are available, guys. Endoscopic sinus surgeries are available. It's a fibro optic. Okay, and this is called as FES, FESS, fibro optic endoscopic sinus surgery. They can put an endoscope from the nose. There is a camera behind in front of that, or they can see directly, and they can do the surgery. Less invasive, okay, less invasive. So of course, like these are new techniques which are there. Okay, then we will go for an enterochoanal. Now, now this polyp arises from the mucosa of maxillary antrum. Okay, and comes out of it and grows in the choana and nasal cavity. What is important about this one, guys? This one have three parts. See, this is the antral part, okay, which is basically have a thin stalk. It have a choanal part, which is round and globular. It have a nasal part, which is flat from side to side. Okay, so like they are showing you nasal enterochoanal polyp. Okay, this is what I was talking about. Okay, guys, the exact cause of this type of polyps is not known, well known. Okay, and they're still confused. It could be nasal allergy, it could be infections, repeated infections. Okay, but the exact cause is not known. What you have to remember, guys, it is mostly single, it is mostly unilateral. Bilateral model are mostly bilateral, they are mostly multiple. And symptoms, uh, now that one is bilateral, so complete nasal blockage. This one is unilateral, so nasal obstruction on one side. Okay, and for like sometimes that this tumor, this polyp or tumor, yes, polyp can be called as tumor, is grow so big that it block this area, all this area. In that case, of course, like bilateral nasal blockage will be there. Okay, so of course, like when this is the case, when it become too big, it is blocking all the nasopharynx, so the voice become thick and dull, which is called as hyponasality. Many people their voice is like this, and these are the people who have all the time nasal discharge coming out, usually mucoid, okay, which can be seen on one or both sides simply. Signs when you are going to examine them, uh, most of these, they grow posteriorly. So sometimes, it can be missed on anterior rhinoscopy. So what we have to do, we have to do posterior rhinoscopy in that case. So whenever we will see them again, you will find that then they are smooth, they are grayish color, and they are mostly covered with nasal discharge, and they are soft, and you can move them easily by the help of the probe. Okay, see, it is soft and can be moved up and down with the probe. And uh, sometimes like if it is too big, and there is like it is strangulated at some part, so maybe it will appear pinkish in color due to congestion. So this is what you can say the signs. And so we do posterior rhinoscopy. Like if you cannot see it on anterior rhinoscopy, of course we go for posterior rhinoscopy, and that reveal a globular mass filling the choana or the nasopharynx. So large polyps may hang down behind the soft palate and present in the oropharynx. Okay, so in that case, it will be hanging, and when you will open the mouth, you can see on the back. Okay, when you examine the mouth, you can see this thing. Okay. Uh, Differential diagnosis, of course, I told you about angiofibroma. Bleeds when touched, and never examine, never touch it if you are suspecting angiofibroma. Sometimes, for example, it could be mucus blabs. Like if you will clean your nose, if you will blow your nose, they will go away. Hypertrophy of choana, the middle part, pink and hard feel of bone, of course, because we are talking about the differential, so we have to talk about all the possible things which should appear like this. Okay, and it could be any other type of neoplasm simply. So guys, like this is about entrochoanal this one. Okay, now how we treat this one, it can be easily removed by avulsion. Okay, by oral route, by nasal route. Simply they take it, twist it, and if they can just simply like cut it off. Okay, so they can be easily removed, and the reoccurrence is not common. Okay, in this one, once you have removed it completely. So if they reoccur in any patient, then we do again the same surgery, Caldwell look approach, or we can do endoscopic sinus surgery. Okay, you can say to remove the site of the origin just so that it should not form again. Okay, and of course, like nowadays, like this Caldwell look approach, which I'll show you already, guys. Uh, uh, this one is like not so commonly used because of the what you can say the endoscopic type of surgeries which are available. Okay, less you can say less invasive investigations. You can do X-ray in these patients. Okay, uh, sometimes you can do CT scan just to differentiate these type of tumors from angiofibroma. Okay, we can do this thing. These are like some points to remember, guys, about polyps. Uh, you can see uh, if polyps are red and fleshy, friable, and has granular surface, especially in older patients, think about malignancy. Okay, and simple nasal polyps, you know, don't never like miss malignancy, especially if the person is old. So go for histology in that case, of course. And a simple polyp, for example, in child can be a glioma or in encapsulocele, okay, or a meningio encapsulocele. So it should always be aspirated, and it should be examined if there is CSF or not. Because if it is CSF, so be very careful because you can cause meningitis. And multiple nasal polyp in children may be associated with mucoviscidosis, not so common. Okay, and epistaxis and orbital symptoms associated with polyp. Think about malignancy, simply. There are like some of the differences between, you can say, the intrachoanal and ethmoidal polyp. Bilateral spoidal common in adults, of course, the other one common in children. Allergies or multifactorial, not known. They are multiple, they are not multiple, or they are solitary. Bilateral, they are unilateral. Their origin, bilateral spoidal origin is from ethmoidal sinus or unicate process. This one, maxillary sinus, near the ostium. They mostly grow anteriorly and may present at the nares. They mostly goes backward, and that's why they hung backward, and that's why sometimes you can see it from the mouth. They are usually small and grape-like masses. They are tri-lobe. They have three parts: antral, nasal, and choanal. Okay. Bilateral spoidal are common, and these are uncommon. After removal. Okay, so they like they if you when you remove them, they reoccur. When you remove them, they mostly don't reoccur. And surgical choices are almost same. Like when both of them, you can use cardiac look approach. Okay, uh, polypectomy can be done for both as well. So guys, that's all for about the nasal polyps. Actually, the topic today was nasal allergies with nasal polyp, but in my previous lecture, I already talked about nasal allergies. So that's why I'm talking just about this one this time. Okay. So thank you so much.